We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Mason Beard is a Solutions Strategies Leader of the Philips Population Health Management Group. He is the co-founder of Philips Wellcentive and has deep experience in developing flagship healthcare IT innovations. He designed Wellcentive's software application suite and is currently responsible for R&D, product strategy, and future product design. David LaMarche is the Executive Director of Eastside Health Network. In this role, David is responsible for the management and oversight of the integration of Overlake Provider Network and Evergreen Health Partners to create EHN, a unified clinically integrated network combining independent and health system employed providers who can comprehensively coordinate care across the East Side. David is an experienced healthcare professional with nearly 20 years of experience in managed care contracting, business development, finance, and clinical operations. Sarah Rutherford is the Quality Program Manager of Eastside Health Network. Sarah joined Eastside Health Network as the Quality Program Manager in 2017. Prior to that, she was the Quality Coordinator at Evergreen Health Partners for nearly 3 years. She has also served as a Senior Practice Consultant, helping community health centers in Washington State designing reporting solutions for optimizing capitated managed care contracts and quality performance incentive programs. Mason, I'll now turn the floor over to you.
Thank you, and good morning and good afternoon, everybody. We're delighted to have you for this webinar. I wanted to just cover an agenda really quick to tell you what we're going to cover today. So first, I'm going to give you a little brief history about Philips and Wellcentive, and then tell you a little bit about where value-based care is today and our thoughts about what recent legislation is and how that's framing it, and then how you can participate from a framework perspective and a solution perspective in value-based care, and how you define success. And then we're going to go over to kind of the heart of the program, and David and Sarah are going to talk about their success stories and what they're doing at Eastside Health Network. And then we're going to end here with a discussion and some Q&A. So it should be a jam-packed day. So next slide. So a little bit about Philips. Everybody here probably has recognized the brand of Philips, mainly from the consumer side. But Philips, for the last few years, has gone through a transformation and has become a 100% health tech company. When you think about the innovation, we've been around since 1918, and some of the technologies and solutions you may be familiar with, from monitoring to imaging to aging and caregiving, one of the transformations that Philips is making is to get into more SaaS-based businesses, software businesses. So in 2016, Wellcentive became part of the Philips family. I've been with Philips now for a little over 2 years. And before Philips, we founded Wellcentive. I helped found Wellcentive in 2005 to help organizations like Eastside basically participate in value-based care. Participate in value-based care programs sponsored by commercial plans and Medicare, but then also transform the way they deliver care. So we're excited about today's presentation, mainly because we're going to go not only through kind of an academic content on value-based care, but really get into the trenches and how are you going to be successful, and what is Eastside doing to be successful in participating in value-based care. Next slide. So a lot of people will debate and talk about what is value-based care, and what I usually hear, and I'm usually the type that addresses the elephant in the room first, is if I look at my revenue and I look at the percentage of the revenue, what is really related to value-based care, it's a small percentage, but it's growing. So we always like to point out regarding value-based care and looking at the percentages, it is small today, but we feel firmly that it is growing, and all the indicators and the signals that we've seen out there, meaning that there's no turning back. So we did a survey through one of our partners around the percentage of executives that said how much money do you have or revenue do you have that's at risk, and it was 8% of the revenues were at risk. And we kind of position that with another viewpoint of Alex Azar, who is the HHS secretary, who did a speech the other day, well, in March 8th of this year, and it was chock full of signals around value-based care. And I think that there's great quotes, but my favorite quote from Alex was basically, he said, simply put, our current system may not be working for many, but it's not working for patients, and it's not working for the taxpayer. So the way I read that and what I wanted to pass on to you is, yes, today the piece of revenue that you have might be small and related to your value-based care contracts that are at risk, but disruption is coming. And you can advance to the next slide. Disruption is coming if you read the tea leaves and what the secretary is telling us. And I wanted to paint that picture that disruption is coming, and it's going to take delivery model transformation to basically thrive in this environment. And that's why we're excited to hear from Eastside, because we feel like that they are mature enough, they've put together these processes, and they've changed the way to deliver care. So they're prepared for that world. So next slide. So what does it take from a solution or tool perspective to change the way you deliver care? What are the tools you need? I wanted to cover just briefly what we call a framework, and it's very much technology. So if you'd advance to the next slide, everything from a solution perspective starts with data. Creating a longitudinal care record that is high quality, that your providers can trust in, that gives you that view of a patient that's not episodic. When you're changing the way you deliver care, we have to move and pivot from a sick care model to more of a prevention and proactive care model, and you can't do that without data. So there's a variety of different data sources that you can ingest and that a population health management tool or solution should ingest, from claims to clinical EHR data to labs to pre-adjudicated claims. You're going to hear from Eastside what they're pulling in, and also what they're pulling in from the payer and the clinical side. But everything from this framework, it starts with that. That's your foundation, is data. The second piece of this framework is, what are you going to glean from that data? What insights are you going to glean from that? And that's going to help you set up the next stage, which is changing the way you deliver care. How are you going to outreach to the patients? How are you going to start closing care gaps on identified cohorts of patients? That all stems from data and insights, which allows you to target. Once you do that, then you can start, as I say, start the do, which is changing the way you deliver the care. And that's really the third piece of the framework here on this slide. And the last thing is, I think it's about accountability. It's how can you engage patients, activate those patients, and get them accountable, and join you on this journey of transformation, moving from the sick care, episodic care, to something that's more proactive. And that's a cultural change. But there's tools and technologies that help you activate patients and help you engage providers. So from those four pieces, we feel like that's, from a solution perspective, that's the framework. And if you advance to the next slide, it's not just about that technology. It's not about a tool and implementing a tool. It's about a cultural transformation as well. So if you think about what Eastside has done, you're going to hear about this, or other healthcare organizations that are going through this transformation. It starts with a cultural change. We're going to deliver care differently, and I need all the clinical and financial goals aligned to that. In many other webinars, we've talked about compensation modeling, how to get physicians engaged, but it really starts with, in concert with technology, it's a cultural shift, and get everybody aligned to those goals. And that's going to lead into engaging those practices and celebrating those small wins. You need to be focused. We used to define focus as one value-based care contract, and then you rinse, wash, and repeat, and you expand those contracts, but you celebrate each of those wins as you scale this culturally, and you scale through value-based care contracts. And you're going to also build trust, but you better have trust in the data that they receive. Traditionally, I don't think providers had a lot of trust in data that came from just claims data. We're paving the road for more payer-provider collaboration, but I think there's a little bit of scar tissue over the years, looking at the way that they were judged from an outcomes perspective and a cost perspective coming directly from the payers. So that has to be addressed in my point number 3 here, and that's also a cultural shift with confidence in that data. And then bring quality and outcomes to the forefront. Not just volume-based, providers and caregivers need to understand what your goals are related to quality. Quality and outcomes equate to the value of the care that you're delivering, and that's what we're all going to be judged by if you kind of go back to what Azar was saying, the value of what you're delivering as a healthcare system, and we're going to learn about that. And then the last is, I'm going to cover these last few points, but it's about care delivery transformation. You leveraging technology to reach out to patients and close care gaps around patients that might not be seeing you. You look at patients that are going to the ER versus seeing their primary care physician. You need to switch that and change the delivery model. Patients that you know that have diabetes, but they're not getting their screenings done, that's one of the cohorts you should focus on and flip the script to see these patients proactively versus them coming to you via the ER door. So it's not technology alone, it's a cultural shift in the way that you deliver the care has to go through a massive transformation, and we're going to hear about that from David and Sarah now from Eastside. So without further ado, David, I'm going to hand it over to you, and let's hear about your success stories.
Well, thanks, Mason. It's a privilege to be able to share our story. You know, I think the one thing that I would start with is just to thank Philips Wellcentive for the partnership that we've had now for several years, first through Evergreen Health Partners and now through Eastside Health Network. Additionally, you know, Sarah and I get to be the spokespeople for the work that's being done, but the team and group of people who have contributed to this effort across the network, from our independent practices to our member organizations, Evergreen and Overlake, as well as IT and everybody in between. There's a whole army of people who have contributed to this, and some in large and some in small ways, but it has made the process better, and I think our overall tool and approach more effective. So I'd like to just note that. I think too, as we share today, one of the things that we always kind of come back to is we're really still a startup. So as we start to progress, next slide, please. As we start to progress through the presentation, we'll kind of walk through our history and kind of share our story, but this is an evolutionary process. I think there's a lot of technology and tools and innovation in this population health space, both from a technology standpoint as well as from a structure standpoint of what is a successful arrangement and how do we build networks and knit together providers and engage patients and report data and change practice patterns and influence care in a way that benefits everybody. And we're all learning as we go, and some things are well established and other things are in this evolutionary state. So a little bit about Eastside Health Network. So we are located on the kind of suburbs, east side of Seattle, and a pretty affluent and densely populated area. We have a number of competitive entities in our space, and so this market really requires a lot of attention and making sure that you really focus on the initiatives that will really deliver value. Evergreen and Overlake, the two hospital systems that are the co-owners of this network from a member status, came together and really said, you know, we believe that if we work together in this competitive environment and really look to promote health across the community, that we can deliver better value and we can have better outcomes and member experience. And so in 2017, they codified that approach and the network was started. So we're about 18 months old, and through that, I think we've seen good development and growth from a engagement standpoint from the independent providers as well as those who are employed. Next slide, please. So as far as structure, again, Evergreen Health Partners and Overlake Provider Network both came together. So these were established clinically integrated networks. Evergreen had been around for several years. Overlake was newer, and said, you know, geez, I think if we look to work together, we're going to be more effective. So they came together under the framework of Eastside Health Network. And now we've developed our infrastructure, and you can kind of see this is a typical structure. One of the things that I think is important and why we continue to be mission focused the way we are is that it's a physician-run, physician-led network. So the board, for instance, has 18 members on it, 16 of which are providers. And we have really good balance between primary care and specialty care, as well as independent providers and those who are employed by some of the hospital systems. You can see the contract and the network development and cost utilization and patient experience, typical areas that you would have within a network. But again, physician staffed and physician led. So keeps us tethered to the things that are important and asks us, over and over again, what our mission is and how we should approach this work. Next slide, please. So a little bit of our footprint. We are ever growing up to about 1,350 providers, and you can see a scattering of primary care, urgent care, and hospital facilities. I think the thing that's really important and is not 100% clear here, but we actually have more independent providers in our network than we do employed providers. And I think this really brings balance and helps us understand how we connect with people across the community, not just at the hospital hubs that are part of our network. This has been part of our challenge, and I'm going to pause here briefly and let Sarah share some of the infrastructure work, because as you look at this, and the scale here is challenging to grasp, but this is a lot of geography and a lot of practices. We have 185 practices, 41 primary care locations, and the challenge for us from a integration of data and from an integration of membership and really how we approach population health is all of the different EMRs. We think we're north of 100 currently across all of those practices. Some of them are very specific. Most dermatology practices have a particular EMR that they're using, but they're not integrated into an Epic or a Cerner. And everything in between a fairly expensive product that might be in some small practice, as well as a few practices who are even on paper. And so the evolutionary process of trying to pull all that data together has been really challenging. So Sarah's going to kind of give you a framework of the integration work that's been done over the last several years.
So certainly with a large prevalence of independently practicing providers in our network, our clinical integration complexity is maybe a little bit unique compared to other CIMs. And starting to work with Wellcentive in 2015, we've developed 13 clinical CCDA and HL7 interfaces from primary care EMRs, which covers now about 80% of our primary care network. These EMRs include Cerner and Epic from our member organizations, and then GE Centricity, Greenway, Athena, eClinicalWorks, and Amazing Charts, the usual suspects for most of us. We've developed 12 payer configurations to support our commercial and Medicare Advantage contracts. These include eligibility files, medical claims, pharmacy claims, and ADP or census data of hospitalizations and ED visits. We've also incorporated the Johns Hopkins ACG risk scoring model into our application. We've built 230 or so alerts to support our workflows, and then about 20 patient compliance reports that we use regularly across our care teams. We'll delve into some of those examples a little bit later. Next slide.
So as we've worked through how we're going to approach care in our community and try to knit together the providers, pull data together, and help understand the resources that we need, we've kind of looked for a true north. Next slide. The document you see here has been a product of many, many hours and many, many discussions across the network, but we really now use this as our framework to help understand and convey what kind of investment we're making in each type of contract and how we engage and think about populations in subsets. So I'm going to orient you to this document. We're going to use this document in various slices through the balance of the presentation. But I think it's important to kind of understand our thought process and kind of the hooks, if you will, of how we approach contracting. So across the top and the kind of darker, back please. I'm going to stay on this slide for a few minutes. So across the top, you see the different contract types. So when we look at these incentive-based, shared savings, up and downside risk, and full capitation, we think about the population differently. And there's a lot of reasons that that occurs for us. So if we look in, for instance, at incentive-based contracts, these currently are mostly Medicare Advantage contracts. Often they are focused on kind of process or procedure-based care gaps, looking at coding opportunities, looking at annual wellness visits, and really focusing on things like readmissions and prevention of admissions altogether, managing patients in the right clinical setting. But there's oftentimes not a lot of discrete dollars related to how your financial performance occurs. So looking at medical loss ratio or some type of a targeted per member per month cost target. Frequently in these contracts, at least early on in your engagement with them, that's not present. It's really kind of, form follows function in a way, and such that if you actually close the care gaps, you manage your readmission pieces that are discrete and kind of episodic pieces that can be reimbursed for from a population health, clinically integrated network perspective, you're going to perform well on the cost side too. Over time, those contracts do alter and move into something maybe more focused on financial performance. But early on, it's really kind of the blocking and tackling of making sure that we capture the diagnosis codes and we make sure that all of their either age-based or disease-based testing and screening and things like that are getting taken care of. So we look at that population and say there are certain things that we want to use Wellcentive for and certain things we want to think about from a care management standpoint and patient outreach standpoint. And so you start to see those categories down the left side. Our shared savings contracts, these are typical, the commercial ACO type products. Often the nationals will have products within these. So whether it's a Blue Cross product, whether it's a Cigna or United or Aetna, there are many different pieces out there in the marketplace. We use Wellcentive differently for this population than we do for the Medicare Advantage population. Typically, these shared savings populations are attributed members. So we see quite a bit of volatility in those members who are attached to us from one year to the next. And so as we think about how we want to engage and manage cost and quality, satisfaction and outcomes from that group, we're gonna tackle that a little bit differently. And once we move past this slide in a few minutes, Sarah will actually walk through how we're doing in each of these categories and the work we're doing. For the up and downside risk contracts, so these are typically designated products. Things that are examples for us is the Boeing ACO. This is a product where during open enrollment, a member in our community that is a employee of Boeing has an opportunity to pick a product that has a more narrowed network and has some different tiering in their benefit design, really with the goal of driving utilization into the network so that we can do a better job of managing the costs and tracking the data and the quality for those members. With that, or in conjunction with that, we often see a higher level of ask from the employer and the third-party administrator to make sure that we're doing reporting on data. A lot of times there's also some type of clinical initiative, whether it's managing behavioral health or spinal fusion or something like that. And so Wellcentive brings some additional value in managing some of those pieces as well. But these populations are, because they're designated, they're attached to our network and very often attached to a particular PCP, we have some more ability to engage them and start to think about maybe providing care in a little bit different manner with them. The final area, which we're titling full capitation, and I'll review this piece at the end, really is the employee plans. So both hospital systems, Evergreen and Overlake, have self-funded employee plans. And these are areas where we can start becoming far more aggressive in looking at alternative delivery of care. And we're early on in this piece. I think we've done a lot of work engaging the members or the employees through benefit tiering and design and incenting behavior through opportunities of either narrowing the network or creating some type of differential or advantage, frankly, for services in one area or another. But we're early on, and this is our kind of next step as far as trying to understand how to best leverage that. We have seen good returns historically, and we really see the full cap area or the employee plan, which in a self-funded environment really kind of functions like capitation, is an opportunity for us to really make some headway and be innovative. So So this is really our framework. This is how we think about our contracting when we engage with either employers or payers about new contracting opportunities. We start to ask ourselves, okay, what are the pieces that are important to us for each of these types of contracts? What are the categories we want to watch? How do we mitigate risk that is not warranted? And then we start to ask ourselves from an infrastructure standpoint, how do we leverage the tools and resources that we have available to us? So Sarah's going to take us through, starting with the next slide, go ahead, a walkthrough of each of these categories and then some examples of how we have engaged Wellcentive to support this work.
Okay, as David said, we'll break our population health landscape down to our specific strategies and clinical examples. Focusing first on incentive-based contracts like Medicare Advantage arrangements, our primary strategy is to close gaps in care and increase our star rating. To do this, we've developed patient compliance reports in Wellcentive for each of our contracts to target the individual quality measures within those and existing care gaps within our patient populations. Next slide. So a typical example is a diabetic patient that's out of care with his chronic disease maintenance. Here we might find that he's not had his hemoglobin A1C or urine microalbumin testing performed in the last 12 months and has not seen an eye provider during the same period. Potentially other types of gaps, but I think we are all very familiar with these three diabetic maintenance measures in particular. Next slide. Here's a snapshot of one of our care gap reports in Wellcentive. So this report functions similarly to a registry and brings forward all of these patient cases, clearly delineating whether a care gap exists. This particular report also shows us every patient's last office visit date and whether our team has performed outreach to them within the last 3 months. So it forms the foundation of this work for our population health assistants, to some extent the work that I do, working with our independent practices and making sure that they know where to find real-time data to support their population. Next slide. Next, we'll move to our shared savings strategies. Again, these are typically contracts that attribute patients to primary care providers based on their frequency of visits. The patients don't opt into a particular plan. These are often types of contracts that overlay existing fee-for-service arrangements and provide an incentive opportunity. Here, we largely focus on managing transitions of care to prevent readmissions and avoidable ED visits, and to ensure that primary care providers are up to date regarding their patients' conditions. These contracts are also where we begin to look at managing high and rising risk patients and transitioning from high-cost prescriptions, particularly brand name prescriptions, where lower cost alternatives exist. Within Wellcentive, we'll highlight our high utilizers report used by our nurse care managers in primary care. Next slide. When we use the term high utilizer, we refer to a patient with 3 or more avoidable ED visits within the past 6 months, 2 or more unplanned inpatient admissions within the last 45 days, which allows us to intervene early, rather than looking at a longer look-back period, or a combination of utilization across these care settings. We have a nurse care manager connected with each of our primary care clinic sites and ensuring that patients with repeat encounters in these settings are well coordinated with their providers and accessing care appropriately. So here's an example of our high utilizer report. Again, each of these examples are from the patient compliance reporting module within Wellcentive Outcomes Manager. We found these to be the most effective tool to leverage patient level data and pulling in specific data elements from the Wellcentive chart and care management side. So this population is formed from that high utilizer criteria. Oh, back one slide, please. So formed from that high utilizer criteria that I described, these are all patients, of course, de-identified, the patients that have a high number of encounters within a very recent time period, and provides a report for care managers to review and prioritize. So in addition to the PCP and care managers' names listed in the report, we identify whether a utilization review has been completed for each of these patients within the last 6 months, So this is a review that each care manager is doing and documenting in the system. We include the date of the patient's last ED visit, the last hospital discharge, the last office visit, and the patient's resource utilization band, which is the Johns Hopkins risk stratifying concept that we use most. This particular example shows an administrative view. So we can see, from my perspective, we can see all of the patients meeting these criteria and which care manager is assigned or not assigned. Each care manager's list is typically short and reviewed daily. So this is a longer view. Completing specific documentation in Wellcentive will remove patients from this report for a period of time unless their utilization pattern continues. They'll then pop back up on the report and show up again for re-review by the care manager. Next slide. We have a real-life clinical example to share from this report in one of our shared savings contracts. This example is of a 30-year-old patient who was homeless with history of substance abuse and had had 5 emergency department visits and 1 inpatient admission within a 6-month time period. Our care manager identified him on her high utilizer report and reached out to the last primary care provider that we had on file, which happened to be one of our pediatricians. Surprising, given his age. But this provider had not received records and was not aware of the patient's facility use, which occurred outside of our network. We were aware of it from the daily census data we received from this payer. So this is one of the benefits of contracting for incentives in this arrangement. The care manager then brought in a social worker and huddled with the primary care provider to develop a care plan that fit the patient's needs. The PCP then encouraged the patient to meet with the social worker who connected him with resources and helped resolve his acute needs. He's not had any ED visits since this intervention she felt was successful. The next slide. Continuing on, we come to our strategy for tackling risk arrangements with downside risk. Here we become more aggressive, like David said, pursuing non-traditional care pathways such as phone, e-messaging, and telehealth visits. We refine preoperative criteria for surgical fitness, work one-on-one with patients struggling to manage chronic conditions, and help empower them to build self-efficacy. We also begin to suggest palliative care consultations appropriately for patients such as high utilizers in the hospital, patients that are repeatedly readmitted and frail, working with primary care providers to have that conversation with the patient and family members. Today we'll showcase our uncontrolled diabetics report and provide more detail regarding our approach to care management. We've also been spending quite a bit of time the last year within our Quality and Patient Experience Committee working on a diabetes playbook, which is difficult given all of the variation in practice, both in primary care and endocrinology and everywhere in between, but trying to rein in our success strategies and standards of care for diabetes management in our network. So the uncontrolled diabetics report feeds into this work and is a high priority for us. We know that there's a large population of diabetics in every contract population we work, we sign, and just in the population in general. Next slide. Over the last few years, we've spent lots and lots of time determining where our care managers' efforts are best spent. We focused on a handful of chronic conditions that present what we call the most impactable opportunity for positive patient outcomes, including reduction in risk and cost. This benefits primary care providers by providing them with a nursing resource to keep patients on track with their self-management plan between office visits, and to provide a layer of confidence building and motivational interviewing as a tactic to move them towards their goals. This report pulls in patients from our upside and downside risk contracts diagnosed with type 1 or type 2 diabetes and demonstrating a recent hemoglobin A1C result over 9%. Those familiar with standard quality measures will know that that is a big quality measure in the majority of these types of contracts. We also highlight their latest blood pressure results, whether they've had an office visit within the last year, or whether they're out of care, on the contrary, and any recent ED or hospital utilization. Next slide. Here's an updated sample of this report, limited to the leftmost column. So not all of those data elements are visible in this view, but as you scroll to the right, you do see the ED visits, hospitalization dates, blood pressure trends. We chose to prioritize these patients' resource utilization band from Johns Hopkins risk, since that is our primary risk driver. Their counts of chronic conditions pulled from all the diagnoses we've received from EMR data and claims. And then the flag for office visits within the last year. This will turn red if a patient is out of care, and then green, as you see here, if the patient is following up with a provider consistently. Then finally, you see a trending view of the 3 most recent hemoglobin A1C results on file, along with the dates taken. From these elements, our care managers prioritize their outreach based on combinations of the risk band, HbA1c value, blood pressure values, or a combination of A1C values and inpatient stays. Really depends on who rises to the top and where they have found success within their own reviews. Next slide. So our last patient example presents a 55-year-old woman diagnosed with diabetes, hypertension, coronary artery disease, and obesity. At the time that she came up on our Wellcentive report, her hemoglobin A1C was 9.6%, and her blood pressure was consistently above 140/90. Her biggest barriers to improvement were her work schedule and family commitments. She tried multiple expensive weight loss programs with little success. As a result, her confidence was low, and her feelings that she could actually make change happen were quite low. To engage her, our nurse care manager requested a referral from her primary care provider for ongoing support, education, and coaching. The PCP and care manager together developed a care plan with 2 clinical goals: what the primary care provider would like to see come out of this enrollment in the care management program. And then the care manager met with the patient and established a 3rd personal goal for herself. So something not clinical, but something that was keeping this particular person from moving forward. The care manager and patient then set up weekly calls for education, confidence building, and accountability. After 3 months of those phone calls, the patient had achieved a 5% weight loss as a result of increasing her exercise and making a few tweaks to her diet. Her HbA1c dropped from 9.6% to 6.8%, and she exhibited better blood pressure control within the target range. Lastly, she was able to optimize her medication regimen, decreasing or discontinuing her diabetes and hypertension therapies. We're really proud of this example. We're working really hard by building our team to provide extra support to our care managers, extra support to our primary care providers, so we can see more of these success stories. This brings us to strategies for capitation. On the next slide, David will walk us through.
Thanks, Sarah. So I think as we've looked at the first 3 categories of contracting, you can see the clear application of coalescing data, pulling things together, and then making some tools and reports that will allow you to stratify the patient population and then make some plans about how you're going to do outreach and engage patients. And we'll talk here just in a minute about the importance of the various pieces of contracting that we believe must be in alignment to gain that patient engagement. But moving to the capitation, and again, I think it's a little bit of a misnomer, but it's the term that we're using internally, really, because for self-funded entities, the patient population that they're responsible for really is a complete expense for them. So the 2 hospital systems, Evergreen and Overlake, both of them have full responsibility around the spend for these patients. And so we're looking for ways to improve that number. So when we look at this various items in here, the targets or the tactics that we're starting to talk about, so we start to play in areas where we feel like we have some level of line of sight because often they're using our facilities. And so we're starting to say, well, okay, are we using site of service appropriately? Are there opportunities for us to move to a lower acuity site of service and less costly? How can we engage in different types of care that maybe are non-traditional or are areas where we're not ready to, kind of carte blanche move all of our resources to a particular area, but we can do some investigation in conjunction with our team members to try and say, is this more convenient? Does it provide a better cost opportunity? How are the outcomes and things like that? So a little bit different environment, and one that we believe really is ripe for innovation and evolution. Next slide, please. So looking specifically, go ahead. Oh, perfect, thank you. So we really, again, see this as a learning lab for value-based care. The things that we have done successfully is moving towards custom tiering. So part of the goal for self-funded plans, particularly when you're in a healthcare organization, is that you really want to make sure as much as possible the organization is paying the bills, is also providing the care. Your cost differential between the care that you provide versus what you have to pay often your competitor for is you want to drive that internally. Things like formulary management. So we have really deep level of engagement in the network from a pharmacy standpoint, and really looking at generic utilization and therapeutic alternatives that we can surface to the providers and actually provide them estimated savings on a particular course or dose of medicine. Using centers of excellence strategy where, care that is not urgent or emergent would be done only in our systems, and then really getting our providers engaged in the process of helping to make sure that they inform patients about the differential and their benefits, and helping to bring them back into the network. We think that this is all predicated, obviously, upon good data and clear line of sight into utilization and outcomes for members, so that those changes that we do engage in, or those things that we do differently, we actually have real-time, or as close to possible real-time feedback on how that's impacting cost and care. We really think that going forward, obviously technology is going to play a larger and larger role. Figuring out how to do that in a framework that doesn't have the providers using 50 different tools or applications is one of our big challenges. And so some of it is actually just, where are those services provided and who's providing them versus integrating a whole lot more diverse tools. Examples of that obviously are telehealth, which I think everybody's trying to solve for in some regard, and then also how do we utilize different care providers that maybe are in a non-traditional setting. Next slide. So I'm going to spend about 5 of the remaining minutes talking just a little bit about the network and the goals, because I think that while we can look at a particular tool or a particular data set, sometimes if we don't have the connection to the broader network or the broader purpose, I think it leaves us misaligned. So next slide, please. So what is it that we believe the value of the network provides? So if we kind of put it into 2 buckets, for our patients, having a clinically integrated network really is predicated upon data, right? So how do we have the integration of the data? If a patient shows up somewhere, do we have all of their information? Do we know where they received care? Do we know what medications they're on? And I think sometimes when you're in a system that is either an HMO-based or a system with just employed providers, you can do a pretty good job of that, depending on what kind of care they get outside. But at some point, you do need to coordinate data from multiple disparate sources. And so we believe that the network does that, and that Wellcentive really acts as our hub of data and bringing that information. And Sarah highlighted many of those data feeds that come in. The care team, right, we want to make sure that everybody across the system has access to this data, and some of the resources and tools that are unique to Wellcentive allows us to either do that now, or we're moving in a direction that we believe is really going to differentiate that. Right care and right setting. So this comes back to how we engage our providers. How do they know who's in the network and where they're located? And then obviously it's not just the patient, right? It's a holistic experience from the family and all of the resources. For our providers, and this is one of the big important pieces that I don't think we can stress enough. In every setting that we're in, we do highlight our understanding of the fact that we need to be really cautious of not asking the providers to do one more thing. One more click seems like just one more click, but it's one more piece of work that is often not doing what is most important to those providers, is providing care. And it really distracts, and at the end of the day, that one more click really keeps them from their family. It keeps them from the things that are important to them. And I think, you know, the burnout for providers is obviously a well-known thing. And so how we can enhance provider wellness through the way we approach data sharing and integration so that we don't have to go 12 different places or look up 10 different things is important. So here it's really, again, optimizing primary care by bringing information to them, and then making sure we connect that as a network. The data integration piece is important. And then we really want to make sure that from our provider standpoint, the things that we do from a network and from a data integration view really integrate all of the various members of that care team and help provide the information that the patients and the families and the other caregivers need to make it a smooth process. Even when we are here and using our own system, sometimes it's confusing about where to go and what the resources are and how much more difficult is it for patients. So very important from our perspective. Next slide. And then finally, to close on the main portion of the presentation here, we're talking about just a little bit of how do we perceive what we do. So I'm going to actually start, honestly, with the last bullet point here. I think this is, you have to take the long approach. There are things that we witness and, you know, moments of brilliance, if you will, from a network standpoint where we see people come together and solve a difficult problem. And it's because we facilitated the right environment for them to be able to do that. We brought the data to bear. We created the forum for them to be able to do that. But it takes a ton of work, and it's not for the faint of heart. And really, the more barriers we can remove, the better. We think that, moving back to the top of the slide, we think that this is available for a limited time. This movement from volume to value is going to be an assumed thing. It's going to be table stakes. And so I think there is an impetus to make sure we take the available funds that are present now and that we are bold in how we approach things while at the same time being wise about the risk that we potentially take on. We think for the success of these products, benefit design is absolutely key. Thinking back to the framework document that we started the last section on and thinking about incentive-based versus designated populations versus, you know, kind of these commercial ACOs, the way in which members are connected to their provider and understand the resources that are available to them really impacts their level of engagement. And so we need to make sure that we optimize the mix of contracts and the mix of patients that we have at risk. And how do we actually get engagement is a question that we have to take to the forefront of the table over and over again. So some of the things you see here around network sufficiency, referral management, breadth of services, data integration, it all fits together in kind of a symbiotic system. I think, you know, the other piece that's important is understanding where an organization is from a value-based care standpoint. Not to get out over your skis in taking risk. I think often when we look at value-based contracts, there is a perception around the opportunity for additional volume of members or for the opportunity to control costs. But I think really understanding where an organization stands, having the data available and the tools available to be able to monitor utilization, to be able to monitor cost and understand how your patients are utilizing the resources that they have available is important. You know, the last couple of points there really, you know, provider community alignment and engagement. And I think, you know, as a network that has more independent providers than we do providers who are employed by hospital systems, this is a challenge for us that we work on every day. And we've really worked to be strategic about engaging those providers, whether it's helping to support the interfaces from their EMR systems or provide them resources in whatever format is most useful for them. So we would love if every provider group had somebody designated to be in Wellcentive day in and day out, but sometimes that's not possible. And so how are we going to utilize that data and harness the resources they do have available? Do we have to generate reports? Do we have to even, you know, heaven forbid, print some of this stuff? But having that central repository is key. And then the payer employer partnership pieces are really important for us because we have to ask for data and we have to get it in a format that we can use it. So it's a long approach. We're excited about the work we're doing. We know we have a lot to learn, but it's been really great to have partnerships, whether it's employers, whether it's payers, or whether it's Wellcentive. So I want to pause. I think we're going to move towards a Q&A portion, but thank you for your attention and time.
Thank you, David, Sarah, and Mason for that fantastic presentation. And we will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send, and we will try to get through as many questions as we have time for. We've already had several questions come in throughout the presentation, so I'll go ahead and get started with those. And the first question that we have today is, what is the ratio of care managers to patients?
That's a great question. So, if we go back to that 4-quadrant contracting grid, we really have begun to try to view that in a way that would say, what is the right ratio of resources that we actually can fund, right? We would like to be all things to all people, but it's not possible. Some of our contracts have discrete requirements about what care manager to high-risk member looks like. And does that require a care management visit with a provider where we develop a care plan over the series of like an hour-long visit? Those are some of the requirements in some of our contracts. So as we sit right now, it's a work in progress. There's a lot of different information out there. We've done a fair amount of research from, there's all, whether it's, the advisory board or whether it's other institutions who have done some frontline research on this. Kind of the number that's out there from a high risk standpoint and moderate risk is 250 members to a care manager. But I think, there are other ways to look at that. One of the challenges we've had with care management is how much time is a care manager spending providing, and our care managers are nurses, how much time are they spending providing nursing skill, and how much of it is administrative skill. And so by partnering population health assistants with nurses, we believe that we're going to hopefully get to a richer level of cost and scope that'll help us broaden that number.
Thank you very much. And we'll go ahead and move on to the next question now. In this question, it would be directed towards David and Sarah, I believe. But the question is, what led you to select Wellcentive, and what challenges did you face in integrating multiple EMRs and obtaining buy-in and data from the health plans?
Oh, that's a big question. So back, let's see, Evergreen Health Partners went to RFP for a population health solution in 2014. And at that time, the landscape for technology looked quite a bit different. But what they did know at the time was that they needed a solution for care management, a centralized documentation repository, and then they really, really needed a solution that could integrate both claims data from payers and clinical data from EMR feeds. So at that time, there weren't many solutions that were able to do that, and Wellcentive was able to check all those boxes. So we signed in 2014 and implemented in 2015. Can you remind me of the next part of that question?
It was just about the challenges that you face in obtaining buy-in and data from the health plans.
Oh, and there's a question about some challenges with the clinical feeds, as I recall. So I'll answer the clinical piece first. The biggest challenge with integrating the clinical data has been working with the EMR vendors, which probably does not surprise many of us. But getting into their queue and getting into the right resource team has been a bit of a challenge. Some are much more streamlined than others, but that process has improved quite a bit over the years. I've been at this for 3.5 years now, so it has improved. And like I said, we have 80% coverage across primary care now, which is outstanding. So then with the payers, most of these contracts, when you contract at a CIN level and for incentives, really dig into some data sharing requirements on both sides. And so depending on quality measures and what the provider network needs to provide back to the payers, that may require that we provide some lab data or blood pressure data, things like that, to support robust reporting on quality. The payers, on the other hand, recognize that for us to be successful, they do need to send us a claims feed of all patient activity, whether it's occurring within our network or outside our network. So we do see leakage, out of network utilization for patients that are included in that population by contract. That's how we're able to solve for that layer outside our walls. But as David has mentioned, it's really crucial that we start to set up some guardrails and clinical guidelines for pulling that utilization back into our provider network. And then what's a little bit more tricky, I think, is receiving timely hospital and ED notification data from the payers. This varies a little bit, but some of them do it very well, and some of them use a third-party vendor to solve for that. And so we tend to just work with whatever is the path of least resistance.
Great, thank you so much, Sarah. And we still have several questions coming in, so I'll go ahead and move on to the next one. And this question is, how do you provide individual quality, cost, and patient experience data to individual providers to engage them in the process?
So I think Sarah and I will tag team this one. I think first off, part of our goal as a clinically integrated network, obviously, is to try to put information in front of providers that help them improve their practice patterns. So we have to receive data from them or in conjunction from them and the payers, and then be able to take that back. We've started in areas that we believe are the most innocuous, so generic utilization.
Prescribing,
yeah,
pharmacy utilization.
So we want to be able to put that in front of a provider, have an opportunity for dialogue, but really our goal is to say, we think there's some opportunities. Not every single person can move every single script to a generic, but largely there's opportunity there. So that's the first thing. I think then, the providers are driving these quality committees, they are driving the board, they're driving all of it. And so their appetite for data is significant, and they really want to have this information. So as we start to move forward, we'll be reporting on how their patient panels progress. How are the care gaps getting closed? How are the star ratings getting kind of captured? What about, HCC scores? What about readmissions? And, sometimes we're challenged on an individual provider basis just due to a small N. If you have one readmission in a patient population, sometimes that can throw something off. But our goal really is to drive that, first as a network, then to a clinic level, then to an individual provider level.
Yeah, and I think in a lot of ways, especially when you're working with small numbers of patients, smaller populations, as these contracts really ramp up and become more of the norm, it's difficult to provide representative data to providers. But we spend quite a bit of time getting out to the practices, educating the practice manager and the providers about what we're trying to do and really what these transformational activities contain. One of our medical directors early on in the process told us, what the work is. And told us as program managers and coordinators, what the work is. And even in the absence of data, that if you do the right work, the data will show progress. So a lot of that, even though it doesn't satisfy those data hungry appetites, when we do have an absence of that, we can at least speak to what we do know. And those are really basic principles and guidelines for providing the right care in the right setting.
Thank you so much, David and Sarah. And it looks like we have time for about one more question. So I'll go ahead and move along to that one. And the last question today is, how do you go about identifying physician providers that you would prefer not join the network and or those that are in network, but you would like to invite to leave? This could be based on clinical quality, et cetera.
So I think this is a tough question. With any network, we're obviously wanting to ensure several different things, right? We have to have enough adequacy from provider count, from geography, making sure that our patient panels are open, that there's capacity for additional members to come in, and for member choice and member selection. With any clinically integrated network or any service, obviously there's some type of foundational piece of work. We utilize the hospital systems for our credentialing process. And so from that kind of checkbox standpoint, we have that covered. We're going to be at some point in a place where we have clinical data that we'll be sharing with providers. As the way the infrastructure is contemplated currently, if a provider was not performing well, there would be an opportunity to have a conversation with them. Sometimes it's, just current on a particular disease state or process or things like that. We don't anticipate gross negligent type issues being a significant concern. And I think, we are also trying to make sure that the front gate is well monitored. So when we go out and meet with provider practices, we walk them through the requirements of the network when they want to join. So we'll say, here are the data reporting elements that you have to be willing to present. Here are the things that are kind of the hurdles from a geography standpoint, from an access standpoint, from a participation in clinical quality initiative standpoint. And sometimes provider groups that's not their cup of tea, and they say, well, I think maybe not, or they may have different approaches. But I think you're right in the sense that we have policies in place, and we have talked about this, but it's a difficult conversation and a difficult question to answer, I think, kind of crisply without an example. Hopefully that helps.
Thank you so much that was a great question and I think a helpful response. Unfortunately, that is all the time that we have for today, but I do want to once again thank David Lamarche, Sarah Rutherford, and Mason Beard for their excellent presentation, and special thanks to Philips Wellcentive for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.